Welcome, everyone, back to the start of our academic year. My name is Joe Kolars, and I'm the director for our Center for Global Health Equity. Thank you for joining us on our first in a series of conversations where we're trying to really tackle what it means to have global health equity. This seems to be a term that has really been growing in popularity. What does it mean? And how are we going to act on that as a center? Just before we get started, for those of you who may be new to our center, please check in with us on our website. If you just put in Global Health Equity at University of Michigan into the search engines, you'll get there. We're a relatively new center, but we're really building connections both across our university, but most importantly, with our colleagues and partners in low and middle income countries. Probably the foundational principle of our way of operating as a center is developing communities of interest, or what we're calling communities of practice, where interested individuals are coming together around themes, around pressing issues, and trying to pursue pilot funding, training opportunities. So please connect and find a way to be part of our conversations, part of the movement, which is bringing so many of us together in unique ways. For this session, we're talking about bringing equity to the forefront of global health. And I couldn't be more pleased to have such a dynamic panel of individuals, a Minister of Health, a Dean, one of the luminaries in thinking on this space from our own School of Public Health. And the format is, you'll hear some prepared comments for each of them that are relatively brief, because what we're trying to do is set the stage for conversation and dialogue. This presentation is being recorded so that other people can have access down the line. You'll have an opportunity to put questions into the question box so that we can really drive a good discussion in the latter half of the session. I'll also be reminding you at the end of the session that this is the first in our conversations about global health equity, as we try to really build the case of what we're going to do collectively for impact in this arena. Some may misconstrue this topic as semantics, because over time, I think the terminology for those of us interested in global health have evolved. This is a paper 3 or 4 years ago, and it acknowledges that many in public health think global health is actually part and parcel of what they do, and I subscribe to that. Global health is so focused on population health, which is the real bedrock of public health. So there's always been what's shown here, these big yellow spaces of the gravitational pull of public health. But then we've had evolution of these terms. When I got started in this space, it was called tropical medicine. Then it became international health. And then geographic medicine, One Health, global health. There's a real evolution here of terminology that you'll find in the literature. Most recently, we're seeing a lot of reference to planetary health, how we're all part of one major ecosystem that is particularly under threat with what's going on in the environment. So there's a lot of terminology. I sense that academics tend to do that sometimes. We refine the way we talk about each other. The key challenge, I think, in these labels and this terminology is who's doing the speaking and where do they emanate from? global health is largely a term that, if we're really critical about ourselves, it's come from advantaged countries, often in their attempts to colonize or to conquer. And it's terminology that the people who are really empowered tend to use without the voice or the perspective of those who are living under a thumb or under a boot of oppression. Often this is economic oppression. But I think we have to be very mindful of how we talk about this, and who's talking about it is something that requires much more scrutiny than we've given it in recent times. I like this picture of the elephant here, and how mindful we're all becoming of the role of power and privilege. And if it's people in power and privilege that are stating the terms, are defining the agenda, who are orchestrating the conversations, it's problematic. This has given way to a movement that many of us are quite excited about, decolonizing global health. How do we let the voices take charge, take control of those arenas where these issues are at play? So it's more than just a semantic discussion. I think it reflects how we view forward motion, how we come together with our colleagues who will teach us, how we enter into co-design, how we completely avoid imposing our agendas and our viewpoints when usually it isn't our lived experience that we are trying to engage with. So that's why I'm very happy to actually start off this conversation by introducing to you Dr. Leah Tadesse. Leah earned her medical degree from Jimma University. She did her specialty training in obstetrics and gynecology from Addis Ababa. And she moved into a leadership at one of the new schools in Ethiopia that's at the forefront of the new school movement, being more accountable to the health of the people of Ethiopia. As CEO and vice provost of St. Paul's. She was in leadership there before moving into a number of leadership roles and projects with USAID, PIGO. And then she actually stepped into one of our own University of Michigan projects, CERT. Many of you know the Center for International Reproductive Health Training, and was actually with us here on campus for a number of years. In 2017, she was recruited back to Ethiopia and quickly absorbed into the health ministry. She currently serves as the leader for health in the country, as the Minister of Health. And I should also say how proud I am that she is still a faculty member here at the University of Michigan. Leah, thank you for stepping out of your many competing responsibilities right now in Ethiopia. We so look forward to your remarks and to engaging you in a discussion. Dr. Tadesse.
Thank you very much, Dr. Kollars, for this kind introduction. And it's really a pleasure to be joining this webinar today on this very important topic, and also at the University of Michigan, which is my home, also my second home, maybe my first home. And it's really great pleasure to connect with everyone here. And I really am happy to share some of my experiences in this important topic of bringing equity at the forefront in global health. Would you like me to proceed, or?
Please.
Okay, thank you. So maybe most of my talk will be focused on equity, health equity within, based on my focus as the Minister of Health within the country context. because equity is a major strategic agenda also for us as a Ministry of Health, as a health sector in Ethiopia. And overall in the health sector as a country, a lot of progress has been made in the past 10, 15, 20 years in many of our health outcome indicators. But there are still wide disparities in the health status of our population due to many factors, primarily the focus area of addressing equity, especially in the past many years, has been towards the disparities related to geographic locations within the country, as we have different regions with different levels of development within country, but also issues related to issues of course, social status, income, gender, disability, and other contexts which contribute to equity in health services and health outcomes. And also issues like disability, as I mentioned, and also in issues like single-headed households and other vulnerable populations which are impacted by health, equitable access to health care. So a lot of focus, as I said, has been done primarily to the geographic disparity, especially a large number of our population is a rural community, but also within that, there is a difference with agrarian and what we call pastoralist, or those living more in lowland areas who have many challenges in terms of infrastructure development, the socioeconomic status, and all which are impacting, of course, the health outcomes. And with special attention, so there was a strategy to give a special attention to these regions to ensure that this disparity, this gap in health outcomes is narrowed. And we have been working as a health ministry with other sectors in improving the infrastructure of health. For example, the number of health facilities were very low. Number of health workers who would go to those regions or those areas to serve would be very low. So incentivizing and those health workers to go and serve in those areas, as well as working to address also the wide range of sociocultural beliefs and that contributes to behaviors that undermine health and health-seeking behavior and service utilization. But as I said, although we were focusing mostly on this geographic inequity, but there's many other factors also needed to be addressed. So recently, we actually developed a national health equity strategy, which was mainly in line with the WHO equity framework, with the three broad dimensions that we have tried to work on, which is access to healthcare, uptake of healthcare services, and also the third one being the difference in health outcomes. So we are trying to address in all these different areas, in addition to the geographic interventions, like to scale up the access to healthcare so that all have equal access to basic goods and services, and reduce barriers like distance, price, and sociocultural barriers. But also, even if the access is there, all people do not use available services. So the second one of uptake is really a critical one, because our utilization is still low in many areas, due to many factors in addition to distance, being attitude of also providers, the community itself, the expectations of, for example, of where a mother should give birth based on the culture and norms, and also the challenge of not receiving the quality expected in those areas. So to address all this, the uptake, especially focusing on the quality also, to ensure that those barriers are addressed, is key. And the third one, to improve the health outcomes, the key one is most of all the health outcome indicators are impacted by of health outside of what the health sector really can achieve, like water access, safe water access, road infrastructure, and many other, education, and many others. So this is where we are now trying to have a strong multi-sectoral collaboration. Fortunately, this is supported also by higher level government, with agenda of special support to the developing regions, which was established some years back to enhance our effort in geographic disparity. And we have been giving, since as a federal government, our ministry supports all regions, but we give added special support to those particular regions. But additional to this geographic, I want to just highlight a couple of things. One is a gender disparity is one key area we're trying to address, both in access to health services to women, but also in their contribution as health workforce, not just as beneficiaries, but also as health workforce. And also the other big focus we are now giving is in disabilities, persons with disabilities, which was quite a neglected area, especially the physical barriers in health facilities and so on. These are some of the things we are working on particularly. And also in the recent challenge that we're having with the conflicts, access to placed population is really one of the equity issues we are trying to address. So this, I think, on the national one, I'll just say a few points if you give me time on the global health aspect that we are working on with our, of course, many bilateral, multilateral partners across the globe. The one is, of course, the vaccine, COVID vaccine issue, as you all know, but that I have been engaging also, not only as a minister, but also as a co-chair of the COVAX AMC group. So one of the big challenges we have been facing is a vaccine, inequitable access to vaccines. Can you hear me? Sorry.
Yes, we can hear you.
And that there's a lot of course, global efforts trying to address this primarily with the COVAX facility, but also within the African continent. The AVAT has been also established to address this for the continent, and a lot of efforts are there. Although, unfortunately, despite the strong efforts, the outcome is not as we expected. As you know, only 2% of those in low-income countries are still vaccinated at this point, which is increasing, of course, by the day, but still very low. And the other area we are trying to work on is also access to tertiary care, which is a big gap in other countries that we have. Where the need for some specialty care is really limited within country, and we're working with many other countries to establish both the services here, but also use an exchange, especially the training programs in specialty trainings, like the one we have established a partnership with Michigan and other universities to really create that capacity in country by developing the capacity of tertiary care, because only those who afford can live to the other countries. The rest usually do not get the care and suffer from those lack of access. So just to highlight, these are a few of the areas that we're working on focusing in equity. Thank you very much.
Thank you, Dr. Tadesse. Often when we're thinking about equity, we're thinking about, those of us who sit in privileged countries and looking to other places that aren't as advantaged. But you just walked us through the equity issues you have to deal with across your country, I mean, within country. That is something that needs to be an important part of our conversation, and hopefully we can bring that out a little bit more in the discussion. I'd now like to turn to Dr. Abebe Bekele in Rwanda. Dr. Bekele received most of his training in Ethiopia, where he became a professor of surgery, rising to leadership positions at the largest teaching hospital in Addis Ababa, Black Lion, and dean of the School of Medicine of Addis Ababa University. He's internationally recognized and particularly active in the region. And it was no surprise to any of us that he was selected to be the founding dean and vice chancellor of a brand new university, the University of Global Health Equity in Rwanda. I think this is the only university that has global health equity in its name. We have that in the name of our center, and it's utilized by many centers now. But Abebe is a close friend of the University of Michigan. We've been here several times, and we're so glad to welcome you to this discussion. Dr. Bekele?
Thank you very much, Dr. Kollars. Good morning, good afternoon, everyone. Thank you very much for the invitation today, and it's a privilege to join Minister Leah today in this webinar. The topic of my talk is about what the university in the globe, how the university defines equity, and what are some of the things we are doing at UGHE that align with our missions and visions. Joe, at the beginning, you talked about the evolution of global health. Some 40, 50 years ago, it started as tropical medicine. Again, its roots in colonial South America and Africa. Then changed it to humanitarian medicine and health, and the concept of global health, public health, was born. And recently, the global health vocabulary has entertained words like decolonizing global health, and words like equity in global health, and now global health equity. When we carefully try to look at the word decolonization or decolonizing global health, decolonization comes with words like power, dominance, and hegemony. There is an oppressor, there is a colonizer, there is the process, the oppression is there. The end result of decolonization is removal of the colonizer. There is a defined enemy. There are words like revolution, dismantling a structure, supremacy. I'm not really sure how these words with the serious negative connotation build on what we want tomorrow. But using the word equity, which is relatively brighter terminology that clearly aligns with access to care, access to education, quality of care, diversity, inclusion, harmony, and more or less talks about tomorrow, is probably the right approach as far as when we try to define health and healthcare access in the 21st century. So UGHE tries to implement and define its approach to equity. Number one, in its partnerships and its desire to create access to opportunities. What do I mean by partnership? UGHE, for those of us who are not familiar with the university, is a global university located in Rwanda. Its headquarters is in a village called Butaro, 2.5 hours away from the capital city in Kigali. It's in the deep rural part of Ethiopia and Rwanda, surrounded by, as you can see in the background behind me, a huge, beautiful green scenery in the middle of nowhere. However, with a big, grand vision to develop tomorrow's leaders and change makers, doctors, nurses, researchers, and public health professionals into leaders and change makers. It's a huge, huge, huge vision. One of our focus areas when we talk about global health equity is that all our students pass through what we call the Masters of Science in Global Health Delivery. These are some of the courses that all our students are mandated to take. These are the principles of global health equity, health policy and political economy. We cannot separate the impact of the current and the past health policies, political economy, history, anthropology, to what we are facing today. Evidence-based global health, that is research, managing global health care, and cross-sectional interdisciplinary leadership. These are some of the courses that each and every student at UGHE passes through. Therefore, our principal aim is to equip our students with the concepts and principles of equity before and after they leave the campus. The second is we're trying to build quality into all the academic programs we are developing. The medical school we have opened is, I must say, a really good quality medical school. However, as you know, quality is associated with expense. And in this part of the world where quality is really expensive, putting tuition fee, coining the terminology tuition fee to academics is systematically selecting those who can pay. Therefore, we came up with a program called Umusanzu, which literally in Kenya, Rwanda means contribution. So all students are given scholarships, irrespective of their ability to pay, where they are from, who they are related to, which tribe or which country they are from. We provide them with scholarships. However, they sign a contract with the ministries of health of the country they came from to serve X number of years, and they pay it forward to their countries. The motto we follow at UGHE is that young people with the heart, the hands, and the minds, in that order, to pursue a profession in healthcare should be given the opportunity to do so. So that's another approach to equity we are experimenting with here at UGHE. As you know, partnership is reciprocity. It's a double bilateral benefit, a win-win association. And real true partnerships do not create a social structure. There is no power disparity, there is no debtor, and there is no creditor. And it by no means is a charity medicine. And our partnerships, we believe that bilateral partnerships in academics, research, and equitable health access is the cornerstone of any partnership we try to develop. And in short, equitable academic partnership can be pillars to improve access to quality of care, decrease disparities in access to care, and strengthen health systems. But as is apparent, unmanaged, unplanned partnerships can easily morph into the new face of colonialism in today's world, the neocolonialism in global health. This is the famous partnership cycle that partnerships are based on: careful planning, understanding the local needs, clarity in the partnership that's being developed, the concept of equity, that is respect, trust, transparency, and ownership. What is the benefit for all parties involved, and what is the capacity building element built into it, and monitoring and evaluation at the end. In short, equitable global health partnership more from the partnerships in the past. Give a man fish and show a man how to fish. However, equitable partnerships probably look like this. First, we need to find out if the man wants to fish and what kind of fish does he want, and then fish together. So this is the new concept of partnerships based on equity. And that is why our founding partnerships at UGHE are mainly the government of Rwanda and its sector offices, the Ministries of Education, Health, the First Office, and our supporters in Boston, including our owner, the Partners in Health. And we have worked with several partnerships trying to build our program. Not all partnerships go well. Partnerships can really go disastrously, especially when partnerships are prescriptive. When several partnerships exist in a country that lack or work against integration, and when they foster research and training programs that do not address the local need. And there is a syndrome we defined known as It's for Africa syndrome. Countries may or are witnessed, sometimes advised, to adopt substandard approaches to processes. There is sometimes extreme focus on task shifting. And when we come to research, just for the sake of inclusion of a few names from the developing world, there is gift and nominal authorships thrown here and there. And some partnerships are built on donations, sharing equipment or donation support can be a good way of resource sharing. However, it can also be seen as a smart way of waste disposal. Good example of a well undertaken partnership is what we have built at the Black Lion Hospital some 10 years ago. This is what I used to run as a laparoscopic STEM center. Very well built, very well run, lots of pertinent training programs going on. And this was my thoracic operating theater at the Black Lion in 2018. Again, based on partnerships running very well. However, in the same hospital, partnerships that are not run well end up with this junkyard behind the main hospital building, to the extent that the partners themselves identify it. So unless partnerships are run and conducted well, they probably signify the wrong side of global health equity, the inequities in partnership. So in conclusion, global health equity, as in my university, that's partnership in academics, is best achieved through mutual dialogue, respect to each other and care, engaging in activities with mutual benefit, the what's in it for me on both sides, developing trust, practicing very good communication, honest communication, and clear partnership roles and expectations from both sides. Thank you very much, Joe. Joe, I think you're muted.
Always my teacher, Dr. Bekele, so thank you. Another brilliant presentation that is going to be food for thought and discussion. I would like to acknowledge we're having just a little bit of video difficulty. I've gotten the word that my voice has been a little bit too soft, so we're trying to compensate there. Also every now and then we're dropping off in East Africa, but we're getting 90–95%. So we're gonna marshal on and still keep working on our presentations and discussion. For our last discussant, before we move to a wider discussion, I'd like to introduce Dr. Ella August, who obtained her PhD in epidemiology from the University of Illinois. She's been with us for a number of years here, where she's now associate professor in our School of Public Health at the University of Michigan. One of her passions is effective writing and communication regarding public health and research capacity in low and middle income countries. She is the founder and editor-in-chief of PREPS, which is the Pre-Publication Support Service, which supports researchers across the globe in publishing their work in peer-reviewed journals. I've always been really impressed by this movement as an enabler for those who are trying to get their work and trying to get their skills up at sharing their own scholarship. Many of us have been turning to Ella to help lead us through a thought process on how we might actually put a definition around global health equity. We've heard some presentations so far really talking about the ingredients. If you look in the literature, you can find definitions of some of the terms that have been used in global health, but not global health equity. So we're grateful to Ella, who's been working with Abebe, with Leah, with a number of individuals to try and see if we can shape these ideas with a little bit more clarity. Ella, over to you. Thank you for being with us.
Thank you. I'm going to share my screen. Can you see my slides now? Great. So thank you, Dr. Kollars and Dr. Tadesse and Dr. Bekele for sharing your experiences and insights on global health equity. As Dr. Kollars mentioned, the three of us have been collaborating and working on developing a definition. We're actually working on a commentary that offers a definition of global health equity, along with Dr. Marie O'Neill and Dr. Joe Eisenberg from the University of Michigan, and Dr. Rex Wong from the University of Global Health Equity in Rwanda. So we've been thinking about how to position ourselves as global health researchers and practitioners in the context of the latest thinking in this space. And I'm going to outline some of our ideas about global health equity. The title of our paper and this talk is using p-values to define global health equity. And we frame our definition in terms of the partnerships and processes that can lead to equitable health products or equitable health outcomes. And I'll say much more about that in a moment, but before I do, I want to thank the center and specifically Christabel Seifa, Christina Rice, and Adrian Klein, who provided a great deal of support throughout the development process for this paper that we've been working on. I also feel honored to have had the chance to collaborate with such an amazing group of colleagues who are, as you just heard, really on the front lines of public health and who provided foundational examples and insights for this work. So as a way of framing our work, and Joe helped, thank you, to set this up already, but I want to start by recapping some of just a few of the major errors, so-called eras of global health, and the language changes that came along with each major era. And I know many of us are already familiar with this history. So what was known as tropical medicine in the 1800s and early 1900s was really about maintaining a healthy labor force to support economic interests like building the Panama Canal. International health eventually replaced the term tropical medicine, and the focus of this so-called era was on high-income countries helping low-income countries. And this focus really highlighted the disparities between these two regions. Eventually, the term global health came into favor, and I think that's the term that most of us use today. The most widely cited definition of global health is by Copeland et al. In 2009. Global health is an area for study, research, and practice that places a priority on improving health and achieving equity in health for all people worldwide. And in this definition, they do explicitly mention equity. And we started our thinking with this question of whether global health equity is really different than global health, and whether the addition of the word equity is meaningful or necessary. So with the help of Cristobal, Christina, and Adrian, we sort of scoured the literature. We were looking specifically for existing definitions of global health equity. So we reviewed databases like PubMed, and we really didn't find much. And one important limitation that I learned about through a conversation with our amazing global health librarian, Preet Rana, is that global health equity as a mesh or medical subject heading term actually does not exist. So what I learned from her is that you can search global health equity as sort of a keyword phrase in a database like PubMed. You'll come up with a lot of articles, and many of which will sort of mention global health equity tangentially. But this limitation doesn't really allow you to search for global health equity as a topic. So because of this issue, and because we wanted to capture voices from across the world, not just in the index literature, we also reviewed Google Scholar, WorldCat, and also we looked at websites from organizations like NGOs and academic centers and other relevant websites that we thought might offer a definition. So one thing we did find from this website review was that there are quite a few organizations now, it seemed like a big increase even in the past 5 years, organizations, degree programs, fellowships with global health equity in their title. And including, of course, our hosting center, as well as the University of Global Health Equity in Rwanda. And I think that shows a meaningful momentum around this term. So despite this momentum, we're unable to find a formal definition of the word, of the phrase global health equity. Like the Copeland definition, there were a lot of mentions of the word equity, both in definitions of public health as well as definitions of global health, and a lot of really brilliant thinking around health equity. But we didn't find any definitions of global health equity per se. So in our paper, we argue that adding the word equity onto the phrase global health is important because our language has a power to shape not only our discourse and our values, but also our future actions, including, for example, goal setting, allocating and sharing resources, and understanding progress in reaching these goals. So we focus on three principles in our commentary that we see as key in achieving global health equity. And these are our P values that we refer to in our title, partnerships, processes, and products or health outcomes of global health equity. So the first principle is that partnerships are really a key launch point for global health equity. So I want to start by describing our ideas, and thank you, Dr. Bekele, for really setting this up so nicely. Before I do that, I want to take a slight detour to reflect on a concept that I'm going to integrate here, and then I'll pick up partnerships again. So here, I want to think about these terms equity and equality. And I'm guessing some of you have probably seen this cartoon already. I really like it because it does a nice job of showing the difference between equality in this scenario here, where resources are distributed equally, but there are still disparities on the left, and then equity, where resources are distributed in a way that achieves important goals and that offers greater support to those who need it or who are less advantaged. And of course, these concepts are quite nuanced and complex, and I'm simplifying things here a bit so that we can come back to partnerships. So for partnerships, arguably the most important consideration in this space is the power balance, and Dr. Bekele again has set this up nicely. So the power, including decision-making and the flow of information, should be equal, and all partners should be, as Dr. Bekele mentioned, receiving mutual benefit. Other aspects of partnerships, partnerships should be equitable. For example, when thinking about resource sharing and contributions. And we did a lot of thinking about partnerships, and I think I probably don't need to add anything beyond what Dr. Bekele has nicely presented to us. Secondly, we argue in the paper that partnerships with the qualities that I just described will foster these processes with these same qualities and dynamics. For example, in thinking about research collaborations, one proxy metric for successful partnerships is the number of papers led by local or host country investigators. With the recognition that with this role comes decision-making power, the ability to frame questions that are relevant from their viewpoint, and the ability to meaningfully contextualize the research that's being produced and the knowledge that's being produced. The third part is this idea that equitable products, this is health outcomes, are the fruits of the types of partnerships and the types of processes I just described. So one example we give in our paper is partnerships guided by community-based participatory research principles. And research has shown that partnerships, sort of in this context, improve the rigor, the practice and promotion of good science, the relevance, as well as the reach, the application, translation into policy, and getting those findings out to diverse audiences. Finally, the last thing I just wanted to touch on here is about our ideas about global health equity recognize environmental health as a key outcome of global health equity activities. You may have seen the recent editorial that was published in over 200 journals, calling on leaders to take immediate action addressing the climate, stating that the biggest threat to public health is climate change. And the point they make is that it is impossible to talk about public health right now without talking about the environment and the climate. And we agree, you can't talk about the health of people without talking about the context. And it's the environment that provides this context, making it central to global health. So to bring it all together, our definition of global health equity is mutually beneficial and power-balanced partnerships and processes leading to equitable human and environmental health products on a global scale. So the culminating idea here is that these three P's are inextricably linked. And this is a figure that we developed that I'd like to leave everyone with as a way to foster more discussion about global health equity and specifically how to operationalize it.
Excellent, Dr. August, thank you. I'm also glad that you reminded us, we're talking about global health, where sometimes our minds drift towards global health care. And what do we do for people who are ill and are wrestling with diseases? But I'm glad that when we're talking about climate or the social determinants of health, that's what we need to care about when we're thinking about equity and how these things all fit together for better health for the populations we're called on to serve. We have a question from one of our audience members. The whole concept of sustainability hasn't come up. Unfortunately, many of us in the advantaged parts of the world, we do these hit and run projects where we come in, we're partners, we're friends as long as we've got this money in our grant. The money's gone and so are we. So there's a lot of efforts that don't translate into sustainability. Maybe could I start with Dr. Bekele? Any thoughts or reflections on that?
Thank you, Joe. You're absolutely right. The sustainability piece of partnerships, global partnerships, is key. And in my opinion, the way we can assure sustainability is, number one, to put a monitoring and evaluation piece, and two, capacity building piece into the partnerships. It's not just about doing a job or doing research or implementing a certain project, but if that is mandated to be tied in together with capacity building, to leave behind well-trained human resources, and then a monitoring and evaluation piece with it. One great example, if I could mention, is the renal transplant program the government of Ethiopia built in Ethiopia in partnership with the University of Michigan. That has been developing for the past 10, 11 years. And look at it now. At the moment, the North-South partnership, Ethiopia-Michigan partnership is evolving into South-South partnership, Ethiopia-Rwanda partnership. And that is how we can assure sustainability. Thank you, Joe.
Great, thank you. Leah or Ella, any comments?
I think Dr. Abebe has put it very well. The key thing would be really from the inception of the design of the project or the partnership, sustainability has to be thought of in the design in terms of one critical issue is what Dr. Abebe mentioned on the capacity, creating that capacity. It should not be an afterthought, it should be from the beginning, but also building the system in place, and the project should be in a feasible way that it can really be scaled. It should not be something that can be implemented maybe in a very specific location that does not address the whole community. So how feasible it is, how can it be scaled by the country or the institution or the government has to be very well thought of from the beginning, from the design of the project, I think, but it's really a critical issue. Thank you.
Thank you, Dr. Tadesse. And I'm reminded that often we go into projects with an outcome being pilot data for the next grant, or to write a paper, or to submit a report to USAID on did we accomplish the goals we set out to do. We're not as intentional as perhaps we could be in thinking about, well, what's the impact we're trying to achieve here? And it's not just through these small milestones of a grant or a paper, but how will people be living differently, hopefully better, because of the collective work. Leah, perhaps could you share some of your reflections? I think one of the things that really came to the forefront for us in terms of equity is what's been going on with COVID, trying to see where COVID is the greatest burden. And it's definitely in our less privileged communities. And we don't look good in terms of vaccine access. Your earlier comment about only 2% of the population, having the COVID vaccine, and it isn't vaccine hesitancy. I think it's more just pure access. I know as a health minister, you're at the forefront of dealing with those issues. Could you maybe share some of those reflections on vaccine equity around COVID-19 that you've been dealing with?
Thank you, Dr. Kolar. So, well, overall, the COVID pandemic, before even vaccine started, I think it's a pandemic that has shown us true benefits of global partnerships and solidarity, as well as the challenge when they don't go well. Especially in the first time when we are responding to the pandemic, there was a huge challenge of shortage of supplies, PPE in many countries because of the overall global demand and the closure of many countries and the like. So there was a need to really collaborate with many countries, many partners to address that. So we have seen how global solidarity was really critical in the response, and we as a country have witnessed. Well, of course, within country also there was a lot of collaboration within sectors and communities, private and government, but also the global solidarity was really very strong. And when we came to the vaccine, that was a thought when we started that journey the thought of really establishing that strong platform where countries can coordinate so that everyone will have equitable access, because this is a global pandemic and no country can be safe even if fully vaccinated, while others are not safe. So that was the thought, and it was really a great idea that came into fruit with the establishment of the COVAX facility, where countries really pledged to support and made sure that all access would happen through that mechanism. But then, of course, when implementation started, what unfolded was very different. And we have been working with different partners and countries to really bring a shift, because, as you know, some countries had doses that were more than their population needed, while some countries were not getting even the first dose in country. So it was globally also a learning curve, I believe, but a challenging one in many aspects. But now slowly things are improving. Many countries are sharing doses through the COVAX, while also trying to improve the access, although we're still far from where we want to be. And at the same time, also platforms, as I mentioned, others like the Africa CDC or Africa Union platform of ABAT also was established to ensure that also there is more access for the continent. So it required a lot of dialogues, a lot of evidence generation, and really almost pleading to many countries to really shift our way of working. Although the principles were set ahead of time. So I do hope that going forward, we will take a very good learnings from this process, because we don't know what will come next also. And this should not be something we will drop, but take very strong evidence of what went well, what went wrong to help us in our current response, but also globally as we move as a global community.
Thank you. Other responses to that, I have to admit, I feel pretty self-conscious sitting in a place of privilege talking about global health equity with colleagues who I can't understand why they're not more cynical with me when they're saying, wow, there's some really basic needs here like vaccines. And here you are talking about mounting a big effort to thinking about booster vaccines and who gets them and who has the privilege even to say they don't want a vaccine, where most of us don't have access to any of it. And so I think people in low income areas are entitled to much more cynicism, and I don't feel it, I don't see it, but I'm very self-conscious of this topic and this gradient when I'm talking about global health equity, when we have some pretty egregious examples of places where those who have the resources are not being equitable at all.
Yeah, I just will add that, there's so much focus on product in some of these discussions that I think our group thinking around global health equity and our approach of focusing on partnerships and process allows us to get much closer to the context and hopefully develop a more meaningful understanding of the context and the problem together.
Thank you. Dr. Bekele.
On a positive note, though, just one thing to add is, I know all this is very challenging, but previously vaccine access to low income countries used to take more than decades when one country has the vaccine and then the low income countries had for the routine immunizations. So at least we have come also a long way in terms of narrowing that gap. So it's not all bad news. So I just wanted to highlight that as well. Thank you.
Thank you. Yes, stay positive. I often need that encouragement. So thank you, Leah. Dr. Bekele, we have another really interesting comment from one of our audience members. Can power dynamics in partnerships really be equal? Don't different partners bring different assets or resources to the enterprise? Using the term equal in definition may be misleading. What are your thoughts or reflections on that whole equality issue and power differentials?
Joe, it's not an easy question, I must admit, but if we define power dynamics based on resources, and that's probably where things would go wrong. Power dynamics cannot just be defined by what resources partners bring to the table. Resources can be human resource, ideas, geopolitical environment, stability, support, leadership, and funding, money. In the first place, why are partners partnering? Why are they in it? That defines everything from the very beginning. If it's to make profit, then that's probably not a partnership, that's a contract. So both parties need to sit together and first identify why are they in it. Good example is if a university partners with a university in a low and middle income country to start an academic program. Why are they in it? The real reason they are in it. Is it to spread or to experiment on a new curriculum they have developed? Is it to spread a new technology they have developed in their university? If that's the case, then power dynamics plays serious issue. It will be a serious mistake. But if the interest is to develop the health workforce, the workforce in a country, to improve access to quality health care, quality health education, then whatever resources partners put in does not matter, because the goal is to produce something. It's driven by I don't want to use the word recipient, but the partner from the South. The partner from the South knows what the problem is. They know what to do. They probably have identified the solution, and they're looking for partners to work with, to work together. Partners should not come with money and prescribe a certain solution. That creates the power dynamics. Partners should not come to a certain country, analyze a problem and say, hey, here is your problem, here is how you fix it. We'll help you only if you do this. And that is why this extreme focus on task shifting and task sharing spread across Africa. We could have used the past 20 years to train thousands of surgeons, had the focus been there. But the easiest solution was to find a way out. This was started 16, 17 years ago. We're still alive, we are seeing the outcomes. That is when power dynamics comes in. So the solution to this is first define why you are in it. Then the power dynamics don't matter. Thank you, Joe. I hope I made some sense.
Brilliant, Abebe, thank you. One of the things that bring people into it, at least that I notice from privileged countries, is they want access for their students to opportunities in other settings. And, you know, and especially in high income countries, privileged countries like the United States, so many of the students now have study abroad programs. There's a strong global appetite. They want to get out there. So often I see my colleagues saying, we want to, you know, we need access to places. Do you have people in Rwanda where we can send our students, or Ethiopia or other countries? And it seems to be a place where we haven't done very well with reciprocity in designing win-win. I have to call out one of my colleagues, Dr. Tim Johnson in OBGYN. As many of you probably know, Ghana is one of our long standing collaborative platforms. One of the things that he championed early on is a charter of collaboration to try and say from the beginning, if this succeeds, how will we each make the other side better? And then setting up structures where we've actually brought more students here to Ghana than we've sent to Ghana. But at least in my travels, I find that more to be the exception than the rule. And especially how are you seeing that from your own perspectives? And what is the role of learner exchange? that having learners around can be quite taxing. We're all academics, we're all committed to the educational mission, but I find this is a tension. How are we setting up these relationships in the role of learners? So thoughts from our panelists.
Joe, I can take a stab at it first. And thank you very much for raising this point. You just described what one partner desires. For example, a university in the US, a medical school in the US, their desire to get out of the partnership is to find spots for their residents to get exposed to tropical surgery, which is absolutely a very good, acceptable desire. Now, the second thing is, who in the developed world, in the developing world, accepts this plan, but also have their own desires. Take my university, for example. If I receive surgical residents from University of Michigan, I would want this residents to be accompanied by a surgeon from University of Michigan, because the surgeon from Michigan teaches my residents, teaches my medical students, while me, the surgeon in Africa, teaches your residents. My residents and your residents create a lifelong fellowship, friendship. Some of my global surgery partners now are those I was introduced to 15 years ago, 16 years ago. And these are lifelong friendships. Research collaborations develop in the middle. You don't just operate every day. You share a meal, you have coffee together, ideas keep coming up. And when you observe problems, quality improvement ideas come up, research ideas come up, to the extent of applying for grants. So there you go. I just described what I want from the partnership. Any two institutions that meet halfway to achieve this two will have a successful partnership. Now here comes the problem. Do you accept, if your residents spend 2 months with me, if I fill their assessment form, will that be accepted at the University of Michigan? If not, then there is inequality, there is inequity. Because I'm just a station where your students stay at for a few days. The equity is when the whole systems, both systems function together. Whatever your residents do, whatever your faculty do here in Rwanda is completely acceptable, maybe in my curriculum. But when your residents come to Rwanda, come to Africa, are the African partners accepted as such equally? When your residents come to Africa, when your surgeons come to Africa, luckily the trend is they don't come empty-handed. They come with research opportunities. They come with resources. They come with books, access to journals. Will those be available to my students, to my faculty? And here comes the equity portion of it. So when institutions begin such partnerships, they should sit down. University A should define these are my wishes. Institution 2 defines this. I'm going to put these resources here. I'm going to put these resources here. At the end, after a year or two, let's monitor and evaluate what we have done. What lessons have we learned? And how can we create a capacity building out of this? So this way, academic partnerships really work well. Thank you, John.
Thank you, Abebe. That was really clear and concise. Ella, I don't think I actually maybe gave you a chance to reflect a little bit more on that word equal. I know you had brought that up in the in your remarks in one of your Ps. And we also have a comment from the audience. For power dynamics, if the equitable partnership is built on goals rather than resources, then perhaps equitable outcomes could be considered in the definition. So I know as you're trying to find the right words and the right succinctness, any thoughts or reactions?
Yeah, these are very nuanced concepts, and it's something we've been trying to untangle as a group. Yeah, so the differences in these terms, equitable and equal, you know, particularly surrounding the partnerships and the processes, we've really thought a lot about different aspects of the partnerships that should be equal versus equitable. And equality is really important. You know, of course, one of the most important considerations is the power dynamic in these partnerships. And so with respect to equality, of things being equal between the two partners, I think that, you know, what we were trying to convey is that it's really key that the decision-making power and the flow of information and ideas should be equal. And that equity, you know, sort of like the slide that I showed, could be more central when thinking about resource sharing, economic resource sharing, and contributions to those partnerships. So, and the second part of the question was about equitable products being in the definition. Is that right?
Yeah, or equitable outcomes is actually the way the question was phrased, but to distinguish it from goals, but maybe equitable outcomes, if that would be a consideration for the definition.
Yeah, definitely equitable outcomes. And thinking about, you know, all of the fruits that come out of these partnerships, and including health outcomes and environmental outcomes. Yeah, I think that is a great point. And thinking about the outcomes of these processes and that we have been talking about.
Great, thank you. Again, more than welcome to entertain anyone's questions or thoughts or reflections out there. I do have we've been talking about the P around partnerships. I wonder if we could talk a little bit about the P around products. Sometimes when universities engage, they really want to engage on breakthrough items, breakthrough opportunities. So for example, Dr. Bekele brought up a renal transplant initiative that University of Michigan was a part of in Ethiopia. And sometimes people come together on cutting edge opportunities, things defined by NIH or NSF. But sometimes the most basic of issues, clean water, sanitation, what's going on with air, they don't lend themselves to really crisp, let's go in there and get it done, set it up and get out. So is there a tension between trying to hit the real leading edge technologies, the leading edge care, when so much of the country is maybe wrestling with more basic things? So is that a tension you feel, particularly as a health minister, Dr. Tadesse, about where you're trying to direct resources in thinking about equity?
Thank you. As most partnerships, for example, to address these large programs that require resources and innovations, when we work with different partners, most of the programs do not directly work with universities, and that's something we are also working to change. Of course, there are, this is what I'm talking about, is the major donors and partners in the health sector. But the key aspect, especially the COVID has been a very good example. We have seen universities were highly engaged in bringing a lot of innovations in terms of the COVID response, and even research collaborations with regional health bureaus, district health bureaus. And we see there's an interface of how the capacity of universities can be used, not just for the training and the research that they directly, that's their direct output, but also from the collaborations that they can bring with district health officers or regional health bureaus on identifying national priorities and working collaboratively to solve those issues with other global partners. So it's really a big opportunity that has not been adequately tapped, but we are seeing encouraging progress as a country. There are more collaborations now because those on the ground, like the district offices, regional bureaus, they know the practical challenge, what is needed to change those. And those in the academics, they have the expertise for research and training. So pairing the two brings a lot of change. So when you add those kind of international, global partnerships, when there are such efforts, I think a lot of solutions would come to the big challenge that we have, because we need, because of the vast challenge that we need, there are a lot of innovations needed to fast track the solutions that need to be in place. So I think globally in the partnership, aside from those university-to-university partnerships, major partners, usually there are very few who work with universities, and that needs to grow in terms of really engaging them to bring change in countries.
Great.
Joe, if I could add a few words to what Minister Leah has said.
Please.
Prioritization of areas of partnerships and engagement are sometimes decided based on faulty information, faulty data. A good example is the discussion around global surgery. As you probably know, for the past 20 plus years, surgery has been labeled as very expensive, not cost effective. The prevalence of surgical diseases in the world is very low. Mortality from surgery is negligible. And the world should not pay attention to global surgery as a public health issue. That was, in fact, proven to be wrong for the past 10 years. There is now conclusive data out there that surgical procedures are very cost effective. In fact, cost effective than vaccinations, breastfeeding, contraception. We have shown that investing in global surgery, the payback is significant. The GDP loss you avert by investing certain amount of money in 10 to 15 years is enormous. It is achievable. There is data out there that shows mortality because of surgery and trauma-related diseases, preventable mortality, is 6 times more common, more prevalent than mortality caused by TB, malaria, and HIV combined. But without this data, public health and global health has been focused on, for all the right reasons, on TB, on HIV, on malaria. So one of the reasons why priorities are set, shall we say, obliquely, is because of lack of adequate information and data. That's one thing we need to definitely work on. The second thing is, economists say supply creates demand. We never thought renal transplant would be, in such demand in Africa until we started doing it in Ethiopia. Now there is huge number in the waiting list. Several African countries are asking for it. When the first dialysis machine opened in a private hospital some 20 years ago, I was a practicing physician. I used to laugh. I mean, why did they import such an expensive equipment? Now the entire, the vast dialysis facility in the whole country is not even enough. So it's a question of finding out the right data, spending time and focusing on the data, and prioritizing what we focus on. Thank you, John.
Great, well, thank you. Well, I know the time is upon us here. And so I'm going to take this opportunity to wrap up, and first to really thank our panelists for what has just been a fantastic discussion, and each of them very busy people who have set aside time to educate us. I hope the term global health equity doesn't become just another attractive phrase that seems to be a little bit different, a little bit jazzy, that we are actually putting the time into saying what we mean by global health equity, but more importantly, actually living it out and making sure that we're working towards the values of equity and have that in the forefront of what we're trying to do together and how we're trying to partner. I'm so attracted to the co-design principles, and I think this is an antidote for what Dr. Bekele was saying about we need to be listening to people on the ground who are living the reality and having them direct us, instead of us trying to cherry pick certain things that may be of interest to us. We are going to be continuing to build on this conversation, and we are going to be, our next conversation is going to be October 8th. So far we've been talking about principles, about definitions, but collectively, we'd really like to think about wicked problems in vaccine equity, exploring challenges and opportunities, and how can we start to come together as a center? How can we start to enter into co-design learning situations with our colleagues in low resource settings? We're building a vaccine equity interest group, and that we hope that those who may be interested would email us and get involved. But this is going to be one of several signature programs for our center going forward. So, please plan on joining us and getting involved. Our next seminar is October 8th. Dr. Tadesse, Bekele, and August, thank you for really educating us, sharing your wisdom, and motivating us to do better and be more meaningful with global health equity. I wish those of you in East Africa a good evening and a good afternoon to those of us here in the US. Goodbye.
Thank you. Goodbye.